Yeah, over to you, Yusuf.
Hello, everyone. Good morning, good afternoon, and good evening from wherever you join us. My name is Yosef Alamu. I am the country director in Ethiopia Results for Development. It's my pleasure to welcome you to this important webinar on the experience and the next steps for integrating early detection and the treatment of wasting into routine primary health care service delivery in Ethiopia. This webinar is hosted by the Ministry of Health of Ethiopia in collaboration with UNICEF and Results for Development. And welcome again, and thank you for joining us. Next slide, please. Before we begin, I want to share a few housekeeping notes. We request that you please keep your self-off video and muted during this event. And we really hope this will be an engaging and a participatory conversation. And the best way to interact is by asking questions throughout the webinar by using the Zoom question and answer function. And the chat function will be disabled. And so please use the Zoom question and answer button at the bottom of your screen to submit your questions for the speakers. And then we will have time at the end and to discuss together. As a note, closed captioning in English can be enabled by clicking the show captions at the bottom of your screen. This webinar will be recorded, and the recording will be shared with all participants via the email used to register for the webinar. We anticipate the webinar to run smoothly and on time. However, please bear with us if there are any network disruptions, and we will try to reconnect as quickly as possible. Please also note that most speakers will also not be using video due to bandwidth. Next slide, please. Yeah, we have an exciting agenda planned for the event today, and we will start with a keynote address and an overview of the Ethiopia Global Action Plan implementation for wasting, followed by two brief presentations on the process to develop a national integration plan for wasting and on how this plan is being operationalized in Ethiopia. Then we will have a panel discussion focused on call of actions to ensure early detection and the treatment of wasting, and followed by participants' question and answer. Finally, we will be wrapping up the webinar with a way forward and closing remarks. Now it's my pleasure to invite Hiwat Darsane, Lead Executive Officer at the Nutrition Coordination Office within the Ministry of Health in Ethiopia, to give us a keynote address. Over to Hiwat.
Thank you, Mr. Yosef. So good morning, good afternoon, good evening, everyone. So I would like to recognize the organizing team, UNICEF and R4D, Elena Crooks Foundation, for the support of this webinar to happen. So the government of Ethiopia political commitment for nutrition is increasing as it takes nutrition as a human right by recognizing malnutrition as an injustice that can be eliminated through specific nutrition and sensitive interventions. Investing in nutrition prevails as a powerful instrument to build a productive and prosperous nation. The era of SDG have a greater emphasis on addressing malnutrition, so the SDG 2 is dedicated to end hunger, achieve food security, and improved nutrition and promote sustainable agriculture, thus ending malnutrition in all its forms by 2030. Moreover, addressing nutrition not only helps to achieve goal 2, but strongly linked to the nearly 12 SDG goals out of the 17. Thus, the first Ethiopian food and nutrition policy endorsed in 2018 aims to ensure food and nutrition security through implementation of nutrition-specific and sensitive interventions. The operationalization of the policy has been started by preparing a 10-year food and nutrition strategy and its action plan. The implementation brings the effort of all food and nutrition actors together through multisectoral collaboration and engagements platforms, aligning their focus on the full spectrum of improving nutritional status of Ethiopians with priority on nutrition of mothers, infants, and young children and adolescents. Hence, our commitment to working towards alleviating all forms of malnutrition, including micronutrient deficiencies, undernutrition, more specifically on wasting and overweight by 2030. So the policy also entails for working in partnership with different stakeholders, including donors and partner organizations to ensure food and nutrition security through coordinated implementation of nutrition-specific and sensitive interventions. So different investments need to be aligned and support the achievement of an agreed set of results as put forth in the National Food and Nutrition Strategic Plans and other national and global plans such as the Sakota Declaration and the Global Action Plan. Furthermore, the government of Ethiopia has demonstrated strong commitment to scaling wasting treatment within the health sector. Thus, my country has successfully scaled up the community-based malnutrition management services on more than 19,000 health facilities with a service coverage of around 95%, focusing on the management of severe wasting, of course, to improve the nutritional status of children. The government also demonstrated leadership in pursuing new approaches to wasting service that manage moderate and severe child wasting. Increasing number of children have received treatment in hard-to-reach areas through mobile health and nutrition team. System has proven and relatively resilient even in emergencies, such as treating as many as 5,000 children with severe wasting without disrupting the routine services. Even though, despite the achievement, the prevalence of wasting is still high. Nearly 1.3 million children are wasted, and it is still a public health problem in Ethiopia. Also, the prevalence of stunting in children under age of 5 has held steady over the past 4 years. It was 38% in 2060 and 37% in 2090. Nearly 5.5 million children are affected by stunting. So rate of exclusive breastfeeding have increased steadily. However, only 14% of children aged 6 to 23 months have been fed the minimum number of food groups. Progress toward reducing the prevalence of wasting is hindered by environmental and other shocks and projections. Hence, cognizant to a lot of work is needed, the government along development partners efforts to have innovative ways to address wasting, more focus on prevention by delivering key time and age-appropriate IY-safe counseling, the family MOAC, integration of moderate acute malnutrition treatment in the health extension program, documents the learning around simplified combined protocols are to mention some of the efforts. Thus, as a government, we call upon strong collaboration to implement the existing fragmented efforts in concerted effort, and let's realize the global action plan implementation to alleviate or to meet our target toward this wasting. So wish you a successful deliberation, and I thank you. Over to you, Yosef.
Thank you, Hiwat, for sharing those remarks and for setting the stage for why we are here today. Thank you so much. I would now like to invite Stanley Chitikwe, the Chief of Nutrition at UNICEF Ethiopia, to share a brief overview of the Ethiopia Global Action Plan on Child Wasting. Over to you, Stanley.
Thank you very much, Joseph. Can you hear me?
Yes, we can.
First of all, to recognize the Minister of Health, Hiwot, the lead CEO for the Nutrition Coordination Office. And then I also want to thank RFOD for the hard work they have put into organizing this webinar, and Eleanor Cook Foundation. I will take just a few minutes to give you a few highlights of the gap for wasting. First of all, to indicate that indeed Ethiopia has a global action plan for prevention and treatment of wasting. Also, it has 4 outcomes. Number 1, to reduce incidence of low birth weight. Outcome 2, to improve child health. Outcome 3, improve infant and young child feeding. And then outcome 4, to improve treatment of children with wasting. The plan is also costed at almost $263 million. And then the partners who are behind this from UN, it includes UNHCR, WFP, FAO, WHO, and of course, UNICEF. We have not costed, as you could see, we did not cost the pillar number 4, the one for improved treatment of children with wasting, because there are other places where we cost that, either under the humanitarian response plan or the regular development program. So we didn't want to duplicate. The key activities that are going on at the moment is a number of initiatives that we have that are basically trying to address the immediate as well as the underlying causes of malnutrition. That means improving diets, reducing childhood disease, improving household food security, improving care for women and children, and also making sure there's good access to a health environment as well as health services. For that, we have a few grants that we obtained from KfW over a 4-year period, and we will target areas where we have high burden of wasting, like Somali region, Afar, southern parts of Oromia, SNMP, Tigray, and also parts of Amhara, the northern parts of Amhara and the eastern parts, as well as that were affected mainly by conflict. In terms of the actions, I think I highlighted that we basically, following the 4 outputs that I indicated, but we basically formed it into activities that the 5 UN agencies will rally behind to improve the underlying causes as well as the immediate causes. We also have another support from CIF that looks at building resilience in drought-affected areas. That also focuses on prevention of wasting, early identification, as well as treatment. For UNHCR and UNICEF, we work also very closely to support the refugee program. And within that, we are focusing on community engagement, infant and young child feeding, capacity building of caregivers, as well as countrywide support for monitoring and evaluation within the refugee scenario. We also have support that we provide. We also, okay, good. We also have, you can move to the next one. Yeah, we also have quite a bit of support that we are providing for the simplified approaches, and that covers the output number 4. And for that, we're getting support from Bill and Melinda Gates Foundation, working with IFPRI, and also we have support from Eleanor Cook Foundation through the Power of Nutrition, working also with Action Against Hunger. And then we also have support of work that we have done supported by FCDO through Jima University. A lot of this work is quite high level randomized controlled trials, where we are really trying different elements of simplification, like using one product and then also using MUAC, family MUAC. And then we are also interested in looking at the continuum of SAM and MAM treated together. So these are the areas of simplification, and we hope that they will really guide us to be able to move forward. Next one. For the treatment agenda, even though we did not include it in our budgets, we actually support it. And as you can see on this slide, 2022, we managed to reach almost 710,000 children with severe malnutrition. They were treated. And a lot of the treatment outcomes are very positive. They follow the sphere standards. So I think we are making a strong headway on that route. I think the place where we need to put a little bit more emphasis, I think it's commonly agreed, if we really want to start to see a difference, is to strengthen the prevention part, which means addressing the other three outcomes. Next one, please. Here, I'm just trying to show you the coverage of programs, where you see the coverage of SAM and MAM. We realize that I think the coverage of the MAM program is limited in most cases to around 208 waredas out of over 1,000 waredas. So there isn't a good balance between SAM, which is happening in over 1,000 waredas, and MAM in only 208, which means, again, the prevention agenda for wasting needs to be further strengthened. Next one. We have come up also with innovative methods of really accelerating the identification, the early identification through find and treat campaigns. This we mainly use in the northern conflict affected areas, as well as currently in the eastern part and the southern part of the country affected by drought, by the Horn of Africa drought. And to that end, basically find and treat is a combination of rapid assessment and rapid response mechanism. And we've been able to screen over 9 million children, almost 2 million pregnant lactating women, and many of them have benefited also from services. Next one. We have also expanded our partnership with a number of NGO partners, as you can see on this illustration. And this has mainly targeted the areas which are mainly affected either by conflict or drought. And in total, we are almost reaching over 150 waredas, which are very much affected either by conflict or drought. And we're working with the partners that are listed here. This also allows us to really make sure that we are able to timely provide treatment, but also we provide integrated services that help with prevention. Next one, please. I think this was my last slide. Thank you very much. Over to you, Joseph.
Thank you, Stanley, for that overview. With that background in mind, I will now pass to my colleague, Dr. Wasan Nagash, Associate Director on the Nutrition Team at Results for Development, who will share more about the process to develop the National Integration Plan in Ethiopia, which aims to build an operational framework for outcome 4 of the Global Action Plan. Over to you, Dr. Wasan.
Thank you very much, Joseph. I will start my presentation by defining child wasting and integration in the context of this guideline. In the guideline, wasting encompasses all forms of acute malnutrition, including weight for height Z-score of less than standard deviation, less than 2 standard deviation from the median, as well as children having weight for height Z-score of more than 2 standard deviation below the median, or having nutritional edema. And integration in this case refers to strengthening the healthcare system and its ability to screen, refer, and treat child wasting as part of the routine primary healthcare services. Next slide, please. Integration is not an all or nothing kind of approach. It's more of process along the continuum of care. So many forms of partial integration are possible across the healthcare system. So based on priorities, the focus could be on some of the components of healthcare system, or it could be applied across the entire healthcare system. So in the Ethiopian case, integrating all the 6 health system components was considered relevant to bring maximum impact in terms of coverage, efficiency, and sustainability of programs. As you can see from the slide, emergency response is integrated as a cross-cutting issue across the board. Next slide, please. For developing the integration plan, the technical working group utilized the global guide developed by Results for Development and UNICEF. And the guide stipulates a 6-step process that starts with establishing the integration process and ends with launching the integration plan. So this shows how global level tools could be helpful in strengthening country level initiatives if they are properly developed and then intentionally adapted to country level contexts. Next slide. So the process in Ethiopia applied all the 6 steps recommended by the global guide. Minister of Health senior leadership approved of the need for integration and taken the initiative to own the action plan development process. So this was the biggest step in the process because government buy-in, ownership, and leadership are vital in any leadership program design and implementation. So the technical working group was established by the ministry, and the technical working group also developed TOR and work plan. And the program goals for wasting services were articulated at the beginning of the process. This is to ensure that all stakeholders are in the same framework or in the same wavelengths. As we would expect, the goals were further refined as we went along the process. And then a rapid assessment was conducted through desk reviews as well as key informant interviews to explore the successes, major constraints, and enablers, and a set of integration actions were identified. So a draft action plan was presented at a workshop for stakeholders, and that draft action plan was validated. And based on that draft action plan, the operation plan was developed. Next slide, please. So severe acute malnutrition or SAM treatment is being integrated in most healthcare facilities in the country through the health extension program, as Hiwot indicated earlier. So the first objective basically focuses on increasing coverage of wasting services related to the screening and provision of moderate acute malnutrition or MAM services, and increased efficiency by leveraging the existing workforce and by reducing reliance on parallel coordination systems was the second objectives. And the last objective was increasing programmatic and financial sustainability. And this is by strengthening health sector ownership and leadership. Next slide, please. So the following few slides show some examples of constraints and proposed actions by health system components. For example, Joseph, do I have time to go through some of the examples?
Yeah, you have 2 more minutes, and then maybe you can wrap up in 2 minutes.
Okay, thank you. I'll take some of the examples. For example, in leadership and governance, uncertain sustainability of wasting services due to continued reliance on external partners was identified as a constraint, and using a phased approach to ensure adequate consideration of wasting services within the annual budgeting process at all levels of government structures, that's as federal, regional, and Warada, was proposed as an action. Next slide, please. In service delivery, for example, low treatment coverage of moderate wasting services is identified as a challenge, and increasing geographic coverage for moderate wasting services by providing wasting treatment that's both outpatient and inpatient in additional facilities is proposed as an action. Next slide. Next slide again. I don't have any maybe information technology. In information technology, for example, one of the constraints identified related to this is a gap in evidence translation and use of wasting data in health sector decision-making. And the actions proposed include ensuring wasting data is routinely available to decision makers through improved frequency of data feeding, processing, and reporting. Next slide, please. Next slide again. Maybe I can come to the RUTF part. In RUTF supply, given the fragmented ownership of RUTF across different supply chains functions, and at times, there are storage and distribution challenges at the subnational level, especially the last mile distribution to health facilities. So transferring the management of RUTF distribution and storage to the national supply chain according to the readiness at each level of the system, because the readiness differs at national, subnational, and local level, is proposed as a key action, and there is a strong commitment from the government to transition RUTF supply to the healthcare system. Next slide, please. So for the health sector components, or all health sector components, major constraints were prioritized and set of integration actions that can help address this. These constraints were proposed. So, and the associated 3-year operational plan, which Shukru is going to present in a moment, offers an implementation framework to drive integration actions by bringing stakeholders together for a coordinated response. I think that's all from my side. Thanks all for listening. Over to you, Jose.
Yeah, thank you, Dr. Wilson, for sharing the process to develop the National Action Plan and the aspects that this National Action Plan focused on. Thank you so much. With that in mind, we will now hear from Shibru Garbesa, the National Nutrition Program Officer in the Nutrition Coordination Office of the Ministry of Health in Ethiopia, who will speak to how the plan is being operationalized. Over to you, Shibru.
Thank you, Yosef. Good afternoon, everybody, and good morning for others. So, thank you. The next slide. So, almost similar to the process is similar with Dr. Wilson earlier presented. As he said, also we established technical working groups who lead the process of developing this national operational integration plan. Then earlier, as he said, also we conduct rapid assessments. What is the success of integrating our activities? We didn't start from scratch. We almost from in Ethiopia from 2008, we integrate the severe wasting management or severe acute malnutrition in the health system. So what the Texas, what the major constraints, and what are the levers to integrate this early detection and prevent of child wasting into rooted health system. So we go through some rapid assessments. Based on that rapid assessment findings, we developed some action points. That action point reviewed by the draft was reviewed by the technical working group. Some amendments also incorporated on that draft one. Then finally we will present it to the all regional colleagues from regions, especially for the MCH coordinator, maternal and child health core process leads, and the nutrition focal from all regions except Tigray. They are invited, and we will present for them both documents. The integration one that as earlier Dr. Wilson presented, and this also the operational action plan. Then we will sit together and the first creating awareness what do mean global action plan on the wasting treatment. The second, how do we integrate this the service into our routine program. Then we discuss many things with them, and at that time, the next slide, please. So during that workshop, 3 days workshop at Adama, and then during that time, the regional focal emphasized the integration must be holistic to scale up the wasting treatment through primary health care. It needs to focus on holistic because so many projects started in separate way. It's not systematically integrated into the health system. So it needs to emphasize the as a holistic approach to reduce the prevalence of wasting in Ethiopia. The other thing, it needs to, the operations must be detailed activities with budgeted. Without budget, the activities, any operational plans didn't achieve. So they focus on this also. The operational plan must be detailed and budgeted, costed with a budget. They say that one. The other thing is they emphasize also this operational plan should be a part of annual plan and the budget. If this activity is not integrated into the routine annual plan, no one is considered as effective document. So it needs to be aligned with annual plan of the health system sector. So this also another illustration from regional colleagues. And the other things, the treatments of acute malnutrition not stopped by doing treatment. So it needs aligning the development activities of humanitarian nexus development and it creating the fund opportunity also another the repression in the that workshop. Next slide. So during that meeting, we see based on the operational integration of the plan, we develop the operational activity. This operational plan consists, as previously Dr. Wilson presented, it's based on the WHO's 6 building blocks for health component. So we develop activities as earlier mentioned by Doctor. Based on that, we call the work on budget part. The cost, mostly we focus on the soft activities for the 3 or half 2 years budgets. So these budgets based on the around leadership and the governance for service delivery, most of that on the leadership and the governance part, we focus on advocacy, review meeting, the HCCP soft activities, and the delivery service also we cost that one. So such activities and we costed all activities for review meeting, for supporting revision, for workshop. Most of our budget focus on soft activities. So we estimate around 2.2 billion Ethiopian or 60 million USD. This is not including the equipment, medicine, for example, the RTF and the routine drugs, because this activity, or for example, procurement of the routine drugs and especially RTF is very costly, huge. Even in the previous, we are on the drought situation, we work for 4 months. Even 4 months, it cost us more than 100 million USD. So we didn't incorporate into this budget. So this budget only incorporates of activities, not including the RPF. This is the cost we work with regional forecast for the 3 years. Next. Thank you. This is my last presentation. Short. Thank you.
Thank you, Shibru, for those important highlights on how the Ministry of Health has ensured a participatory in the uniterated process to develop a comprehensive integration operational plan, and also for the highlight on the effort in place by the Ministry of Health to facilitate a strong engagement and ownership of the subnational regions to explore on how this operational plan can be integrated into the routine annual work and the budget plans at the subnational regional levels. Thank you so much. Now I would like to pass the floor to Mary De Almont, Program Director of the Nutrition Team at Results for Development, to kick off the panel discussion. Over to you, Mary.
Wonderful. Thank you, Joseph. And thank you, Stanley, Dr. Wilson, and Shibru for your presentations this afternoon in Ethiopia. I'm honored to open the panel discussion and introduce our 4 panelists who will speak to different aspects of wasting integration in Ethiopia. Our panelists include Galila Zudu, who's the Senior Nutrition Advisor at the Federal Ministry of Health in Ethiopia. We're welcoming back Stanley, the Chief of Nutrition at UNICEF in Ethiopia. We welcome Dr. Sisai Sinamo, Senior Program Manager of the Sakota Declaration in Ethiopia and Sun Focal Point, as well as Mulana Germa, who is the head of the Department of Nutrition and Health at Action Against Hunger in Ethiopia. As a reminder to everyone, please place any questions you have for the panelists in the Q&A box throughout this section. We'd love to hear from you throughout and have some facilitators responding directly to questions as they come up. We're planning to get started with Galila, but she had some connection issues earlier. Let me do a quick check to see if Galila has joined us now. Galila, if you're with us, please say hello. And I will open with my prompt. If not, we will start with our next prompt and cycle back to Galila. We'll work on trying to ensure Galila is able to join us. She's speaking us today and sharing the example of integrating nutrition within the expanded program on immunization. So I hope we can hear from her soon. Please advance to the next panelist prompt. Today, actually, we'll start with Stanley. Let me just wait a minute till we get to the slide. Okay, welcome back, Stanley. So in the earlier presentations, Wosen and Shibru mentioned the impressive effort by the Ministry of Health to transition supply functions to the government. Could you please share your experience on the integration of RUTF into the national supply chains and government investments? Stanley, the floor is over to you.
Thank you very much, Mary, and good afternoon, colleagues, and good morning. There are four areas that I could highlight, Mary, in terms of how this integration has happened. But before that, I think we look at integration also from 2 levels. That means the federal level, as well as the regional level. At federal level, I think the key work that has been done so far has been to, number one, make sure that RUTF is included in the essential medicines list. I think legally this makes a big difference. It makes it a priority product to be prioritized for government budgets. Also, it makes it also one of the items that can be integrated into the Absa system. So this has been accomplished. And then the second big piece of work at federal level that was done has been also to working together with Ministry of Health and Absa to Absa is the Ethiopia Pharmaceutical Supply Agency, is to carry out a capacity assessment of Absa in terms of integrating RIUTF, because this, of course, integration means basically integrating into the information system, integrating into the port clearance mechanism, into the warehouse facilities, and then, of course, the logistics aspect, the actual distribution itself. So a report has been produced. It also has very clear recommendations. And I think one of the key recommendations that came out of this was the request by Absa for UNICEF and the Ministry of Health to establish a big warehouse that will be able to house this level of capacity of RIUTF that comes either from local production above 30%, and then 70% at the moment still come from outside. So there's need for huge warehouse capacity. We cannot sort of immediately just integrate into the existing Absa warehouses. Otherwise, RIUTF will overwhelm everything. Now, at a regional level, this is where we see at the moment the most sort of complete picture of integration, because at the moment, once we receive RIUTF, we deliver it to the regions, and then the regions register it into their Absa systems, and then they will then distribute from region to zonal level, from zonal level to Wareda level, and then eventually to the Kebele level, where we have the lowest level of health facilities, which is the health post. So this whole big logistics, we informally did a quick back of the envelope calculation. It's almost worth $10 million every year that the government invests into the final distribution of RIUTF to the point of use. So this is very, very clear sort of illustration of that integration, even though, like I said, it really starts from regional level. Why I say that is that at the moment, we still, UNICEF receives the items, we clear the items, we put them in a UNICEF warehouse. Of course, the government helps us to pay duty for the importation, and then we distribute to the regions, and then the regions take over the logistics part. So I think this is a very strong illustration of integration. And then the fourth area of integration has been pretty much the work we are doing with the ministry. There has already been an agreement from the Federal Ministry of Health to invest $1.3 million this fiscal year to procure RIUTF. So we have a mechanism whereby we can use this 1.3 million to match with another additional 1.3 million from UNICEF Supply Division, where we can then sort of match it to make it 2.6 million. I think it's a good starting point for the government to start to sort of use domestic resources for the procurement of RIUTF. Of course, we know that given the various emergencies at the moment, the demand for RIUTF is still quite huge. And the cost, I think, ranges per year between $60 and $70 million. But I think, as they rightly say, that a journey of 1,000 miles starts with one step. So this is actually a very, very solid, good step from the minister. So these are the four areas that I would like to highlight, Mary, that have illustrated the efforts of the Ministry of Health to integrate RIUTF into the Absa system, the Ethiopia Pharmaceutical Supply Agency system. I will stop here, Mary. Thank you very much.
Thank you very much, Stanley. Lee, if you can please continue forward to the next panelist slide. Next, we'd like to welcome Dr. Sisai. Dr. Sisai, could you please describe the contribution of early detection and treatment of wasting for stunting reduction and the benefits of integrating early detection and treatment of wasting into the routine healthcare system? Over to you, Dr. Sisai.
Thank you so much, Mary. I would like to recognize the presence of Hewitt, the lead executive officer for Nutrition Coordination Office, as well as Stanley, who is Chief of Nutrition at UNICEF, and also Joseph, the country director for R4D. Thank you for the questions that you posed, Mary. I think in terms of linking the wasting into prevention as well as also long-term interventions like stunting, as many researchers have shown that there is a link between wasting leading to stunting, and also to some extent stunting also leading to wasting. So although there is no a clear physiological mechanism established between wasting and stunting, but there is also a direct relationship among them. So in terms of the both at the global as well as also country level, there is a clear strategies, targets for both in terms of reducing wasting less than 5%, as well as also in Ethiopian context for us for ending stunting specifically among children under 2, and also cutting stunting to 13% by 2030, as we have indicated in our food and nutrition strategy. But it's good to also understand, what are the peak age periods where children are exposed to malnutrition, so that we can really understand where we need to put our investment and also emphasis for prevention of wasting. Children specifically those who are being introduced for complementary feeding, as that is the age where the burden of malnutrition peaks. And also studies again and again have shown that there is an increasing trend, especially for children between 6 to 18 months, where stunting as well as also other forms of malnutrition are peaking. So for in this regard, I think when we look at the prevention that we can use within the health system, is one of the key prevention is for us is growth monitoring and promotion, where we can early detect the level of undernutrition among children under 2. And of course, we have also other means when we do the mock screening for detecting early in terms of children are not wasted or not. So if we really strengthen our growth and monitoring promotion activities, that is, will be within the health system an important intervention for prevention of wasting. In addition, the strengthening the infant and the young child feeding practices, especially promotion of the complementary feeding, and also IYSF practices using the community groups at community level. That is something that we can integrate the sustainability of the wasted children in terms of sustaining prevention, while they shouldn't go back to wasting. I think Stanley has mentioned earlier that, for instance, if the current caseload is over 700,000 children which we have treated for wasting, are they coming back through relapse or not? Those kind of things could be prevented if we have a very strong community-based nutrition promotion activities, including the complementary feeding promotion using cooking demonstrations. So we can link those children to such kind of community-based interventions to sustain them not to relapse again in the nutrition back to malnutrition. I think that is now at community level. When we come back at the, I think one of the things which also Dr. Wilson has raised is in terms of leadership and governance. I think in terms of sustaining the prevention activities is how are we using the wasting treatment and treatment outcome data for decision making at community level. For instance, we have the multisectoral coordination at Warada level. How are we using those data for decision making? Whether we are using that as an early warning, information system to make, the timely action to prevent further deterioration of the situation. I think this is some of the things that we need to bring at the leadership and governance level when we think of, multisectoral decision making, because usually the trend will peak gradually, as we know, but you usually respond as an emergency when things deteriorate further. So if we use for instance, the MUAC screening data for early warning, early action, and also early response, that will really help for prevention. And finally, I think in terms of the multisectoral nature of the Sakota Declaration, we have a number of opportunities for sustainable prevention of wasting. I think one of the things is if we could link this with other sectoral interventions in terms of nutrition sensitive agricultural interventions, linking this to the productive safety net interventions. Of course, for beneficiaries are exempted for especially under 2 and also pregnant lactating mothers are under 5 and pregnant lactating mothers are exempted for such kind of interventions. And also if we also use this one for economic empowerment interventions, for instance, those families that are high likely of predisposing to wasting, if they get, the economic empowerment interventions, those kind of things will help for them to sustain the achievements once they come out of the treatment of wasting. On the budgetary side, I think it's good to also to influence using the health system side, but also from a sectoral point of view, the budgetary decision is not only be made by the health sector, but also the finance and other sectors are really critical. So I think it's good for us also to show how the prevention work that we are doing could also contribute towards the economic development of the country, because the wasted children contribute towards mortality, morbidity, and also a lot of burden to the health care. So it's good to showcase of that evidence based to influence the decision making in terms of the budgetary allocation. But also on the other side, I think sustainability of the product is also one of the key issue. So I think the local manufacturing option is also one of the things that we really need to bring in this discussion in terms of sustaining the prevention option. Do we have other alternative solutions that are cost effective and sustainable to prevent wasting before further deterioration? Of course, currently we are treating children after they are already wasted. Do we have other options that we can provide for those poor and vulnerable families before even they get deteriorated? I think those kind of things need to come as we move forward in terms of addressing prevention of wasting in a sustainable manner. Thank you. Over to you, Mary.
Thank you so much, Dr. Sisai, for sharing your experience from the Sakota Declaration and importance of linking programs for prevention and treatment, continuing to strengthen data for decision-making info systems, and many other important points that you raised. Thank you. We can move to the next slide, please. Next, we'll hear from Mulana Girma, who's we've introduced earlier. Mulana, can you please speak to successful ways to scale up services for both the prevention and treatment of child wasting? And as a reminder, please indicate when we need to move to the next slide so that we're keeping track with your notes. Mulana, please go ahead.
Thank you, Mary, for introducing me to the participants. So my presentation will have two sections. The first section will focus on the adaptive and the innovative nutrition services in the context of humanitarian crisis. And the second one will focus on the nutrition information system and the operational researches on simplified approach. Next. So to just give you a general overview of Action Against Hunger operational presence in Ethiopia, Action Against Hunger is currently operational in 6 regions, 15 districts and 5 refugee camps, providing humanitarian and development services, primarily for communities affected by humanitarian crisis. The organization aspires to see a world free from hunger, and it has also a mission to justify its presence here in Ethiopia and elsewhere. Next. So essentially, these are sort of conventional and primary nutrition intervention actions that Action Against Hunger implements across its operational areas. These interventions could also fit into the health system components that Dr. Wilson mentioned. And they are designed oftentimes in line with national and global nutrition policies, guidelines, strategies, as well as evidences, but also based on internal program lessons and experiences. Next. So family MOAC is one of the innovative and adaptive nutrition intervention approach that has been gaining a good momentum here in Ethiopia, especially after the occurrence of COVID-19. And Action Against Hunger has been implementing it since 2020 in 10 districts and 5 refugee camps. So as most of you know, the approach primarily aims to enhance the capacity and the skill of mothers and caretakers of children under 5 to detect acute malnutrition and refer severely acute malnutrition cases to the nearest health facility and nutrition centers as soon as possible. So as Action Against Hunger, we believe that family MOAC approach could serve as an alternative solution to enhance the scale up of the early detection and treatment of wasting here in Ethiopia. Next. What's also worth remembering is the need to consider innovative and adaptive nutrition intervention approach at times of humanitarian emergency and public health emergencies such as COVID-19. As such, Action Against Hunger was able to implement the sort of identified adaptive nutrition interventions during the COVID-19 peak pandemic season. And it was able to document the implementation of the adaptive nutrition service lessons and experiences in the form of case study and articles, which are featured in the major humanitarian news and information outlets such as CNN and Relief Web. Next. Another promising nutrition intervention approach that Action Against Hunger has been implementing in 4 out of 5 refugee camps is what's known as the Mami Cap Pathway. Mami stands for the management of small and nutritionally at-risk infants under 6 months and their mothers. So Mami Cap Pathway is more or less like IMCI, and it offers a special opportunity for vulnerable and target groups to have the access to a holistic and integrated health, nutrition, and mental health social support services. So again, we believe that this is a kind of service that can be scaled up in host communities to further enhance the early detection and the treatment of child wasting, and also to ensure a continuum of care within the existing health system in Ethiopia. Next. So the other aspect is operational research on simplified approach, which Stanley has mentioned earlier. So Action Against Hunger is currently preparing to operationalize two simplified approach research topics. One is the modified dosage, and the other one is the family MOAC. So the modified dosage, also known as the MODAM trial, aims to generate evidence on the safety, effectiveness, and cost effectiveness of a modified dosage protocol for SAM and MAM treatment in relation to nutritional recovery, post-recovery outcomes, and relapse compared to the standard national protocols. Next. Whereas the family MOAC operational research in general aims to assess the effectiveness and cost effectiveness of the approach compared to the standard health extension workers-led community-based screening, but also to assess the short and long-term caregiver measurement accuracy and frequency at community level. And both these operational researches are implemented by Action Against Hunger in close collaboration with the Federal Ministry of Health, UNICEF, Ethiopian Public Health Institute, and the University of Washington. Next. Another area of interest, which Dr. Sisai mentioned, is the need to strengthen early warning system to prevent and mitigate hunger and malnutrition in areas that are prone to drought and flood. And this can only happen through the development of nutrition anticipatory action using a predictive model. So the predictive model does only require us to use secondary data, which are oftentimes available at national, subnational, and local level. So we believe that this kind of endeavors should be given special attention, given the recurrent humanitarian crisis situation in our country. Next. Future research areas of interest, at least from Action Against Hunger point of view, are these ones. The first one is a SAM photo diagnosis application. And the second one is a plant-based RUTF or alternative RUTF operational research. So on the first one, the SAM photo application, this has already been tested by Action Against Hunger in the western part of Africa. And it's proven to be accurate in terms of identifying severe acute malnutrition in stunting by just taking a photo of a child, children under the age of 5 years. And it uses an innovative mobile phone application. So as Action Against Hunger, there is a plan to scale it up to other Action Against Hunger operational areas, including Ethiopia, in the next 5 years. So we would like to take advantage of that strategic initiative. And on the second point, as Dr. Sisai mentioned, we are also planning to operationalize researches in the areas of RUTF alternatives, given the relevance of doing so. Especially, there is a limited evidence on the safety, effectiveness, and the cost effectiveness of plant-based RUTF, and also looking at the possibility of producing those alternative nutrient supplies at local level. Yeah, next. And lastly, something that we are keen to capitalize on is the need to strengthen our nutrition information system, especially the HMIS and DHIS2 system, for us to effectively measure progresses and enhance the community level as well as the higher level decision-making process as far as nutrition is concerned. So as Action Against Hunger, we would like to capitalize our assistance approach on that, whilst we continue to do other nutrition surveys and investigations that have their own purposes and objectives. Next. Thanks so much for listening. Over to you, Mary.
Wonderful. Thank you so much for sharing that experience. Now, we're going to check. Galila, are you with us?
Yes, yes.
Wonderful. Fantastic. Okay, so we'll just zoom right back up to the beginning of the slides. Thank you so much, Galila. Galila is joining us, the Senior Nutrition Advisor from the Ministry of Health. Galila, can you please share with us the example that's been underway? Recently, there's been a campaign to integrate nutrition services into the expanded program on immunization. Could you please share more on the process and vision for the future? Over to you, and so glad that you're able to join.
And sorry, one note
Thank you
just
so
before you
much.
start, Galila, sorry, can you please indicate, just say next when you're ready to go to the next slide? Thank you.
All right. Okay. Got it. Thank you so much. Good morning, good afternoon, good evening, everyone. So I'm going to share the experience that we have in integrating a number of child health and nutrition services in a recently conducted measles supplemental immunization campaign in Ethiopia. So due to the number of shocks that the country is facing, so the ministry has just given a direction to just provide essential nutrition and child health services using this national supplemental immunization campaign for measles. So by taking this opportunity, and making the child at the center, we were able to deliver a number of essential services. So I will be talking about the process we have been through and the achievements we have from this campaign. So the campaign initially planned to just provide measles SIA, has integrated other services, which the majority of these services are nutrition, child nutrition services. So from this, please, the next, go to the next slide. Next. So among other services, we have been able to integrate nutrition services, including screening and referral of a child with acute malnutrition for children under 5, supplementing with vitamin A for under 5 children, and providing deworming services. Among these services, the campaign is also able to deliver other essential health services, including provision of routine immunization for those children who are 0 vaccinated or under vaccinated and whose age is under 1 years old. Also other services, including identification of children with clubfoot and provision of COVID-19 vaccination, were also integrated into the campaign. Coming to the integrated nutrition services, the target population for these services that I mentioned are children under 5 years of age, and the date and duration of the campaign was just provided starting from December 22 for consecutive 10 days. So some of the activities that we did to deliver the campaign include activities that we have at the preparatory, pre-campaign phase, intra-campaign, and post-campaign. So all the activities we did were so integrated systematically, and the process was engaging every stakeholder at all levels. This is one of the important processes which make us effective in just meeting the objectives of the campaign. So as you see, we have a task force established at the national level and also at the sub-national levels that included stakeholders from the side of the nutrition, including government workers, NGOs, and other partners working in the nutrition area, and also from the EPI and other services that are integrated into the campaign. So the task force has a TOR, and we were also having integrated micro planning for the campaign, and also we have provided integrated training at national level, and that is cascaded to the level of the service providers. So we were also having integrated communication activities, including development of different mass media messages and production of banners and so on to inform the communities and other stakeholders about the services integrated into the campaign and how those are going to be delivered. Next slide. So in addition to these activities, we were also conducting integrated deliberation in terms of quantifying, packaging and distribution of different supplies and logistics which are needed for the campaign. So the nutrition commodities are just integrated into the API commodities and are just delivered using the routine supply chain systems, the APSS. Another activity we did is also resource mobilization. So a major contributor investing into the campaign was the Gavi fund, which was around 11 million USD. And government also contributed around 1 million USD. On top of that, from the side of the nutrition, through the nutrition partners, we have been able to just mobilize around 1.8 million, which we contributed this funding majorly to support service providers at the vaccination sites who are delivering actually the integrated nutrition services. Overall, the campaign has an investment of around 15 million USD. Next slide. So during the campaign, we were having a serious follow-up and support of every process. Every day we have the report of the campaign progress, what's been happening, and the challenges that have been faced at different sites. So using different channels, including Google Sheet, ODK, and Power BI, we have these communications and we also provide feedback. So we have a dual communication at all levels. So around 407 experts from the national level alone supported the campaign at every region of the country. Next slide. So these integrated activities have led us into successful deliberation at the end of the day. So as you see, the national campaign has a good success in terms of achieving the integrated nutrition services, including screening and referral of children into the acute malnutrition services. As you see, we have been able to just identify children, a number of children who have got wasting, and these have been linked into service provision sites. These are the good success, in fact. Next slide. Another activity was vitamin A supplementation and the deworming services that we have provided for these children. As you see, we have more than 13,000 children, 30 million, sorry, more than 30 million children nationwide who have been supplemented with vitamin A supplementation, which is indicating us a coverage of around 92.2% compared to the overall targets. In the same way, we also provided albendazole for around 8.8 million children nationwide, which is around an achievement of more than 95% of children who are eligible to get this albendazole deworming supplementation. Next slide. Also the success for the coverage of the measles vaccination is also encouraging. As you see, this success reached around a coverage of 98.5% for those children who are just targeted to get the measles vaccination. Next. Next, okay. While we are doing this large-scale integrated campaign, we have faced some challenges, such as unable to access some areas due to security problems. For example, in one of the regions like Benshangul, we have 7 inaccessible waradas. In Oromia, we have 12 of the waradas, which we can't deliver the campaign due to the conflict and access challenges. Another challenge we faced during the campaign deliberation was an interruption and a bit of shortage for vitamin A capsule. And also we have some challenges regarding target population for each service. So the target that we have planned using census data and the children, number of children in the ground is sometimes different. So due to this thing, as you have seen in the performance, we have achievements which are more than 100% or so. And this also has created some kind of challenge in terms of supply and commodity. And another challenge which we can mention while we have this campaign is just the number of zero-dose children for measles were low because there are a number of children who are unvaccinated and who are assumed to be accessed during the campaign, but the number identified are not as such satisfactory. Next slide. So we have also a number of learnings from this campaign. So as you saw, we have integrated a number of health, nutrition, and other services, and the achievement is very encouraging. And this success is mainly due to the fact that the campaign is very focused and the leadership, the top leadership, senior management, starting from the ministry up to the sub-national levels, have led this integrated campaign, and this is one of the reasons for the success and the focus for the campaign. And also we're having ample time and the engagement of everyone during the preparatory phase. So we have been able to systematically integrate every service at every step and every activity. This is also another success factor. Another one is that we have the involvement of every stakeholder, from the government, from the partners, from the regions, and from everyone, and close monitoring and support of the campaign deliberation is also another success factor that we have taken as a lesson. So this is also very important for us to just take these lessons on how best we can establish a nexus between relevant services such as API and nutrition in the routine service provision activities. So we have taken a number of lessons from this campaign apart from its success. Thank you so much. This is what I have.
Thank you so much, Galila, for sharing that impressive initiative. I'm so impressed by the work done, the performance you shared, and so many lessons learned coming out of that campaign. No doubt the experience will strengthen the programs in Ethiopia as well as provide insights for other countries. Thank you so much for sharing that experience today. I'd like to extend a huge thank you to all panelists for the engaging discussion. We have time for just a couple questions from the audience. Leif, if you could advance to that slide after the panelist presentations. The facilitators have been answering live via text, the Q&A function, so please be on the lookout for a response there. And we only have time for about 1 or 2 questions, and we'll ask panelists to please keep their responses to 1 minute. So the first question is for perhaps Galila, you'd like to answer it. It's regarding the ability of the primary healthcare system to do more. So the question is, do you foresee challenges like workforce burnout and administrative burden to impact the integration efforts? How do you plan to address this? So the ability for health workers to deliver nutrition services at high quality while also maintaining other health duties that they're required to do. Galila, would you like to respond to that question? And I'd also invite any other panelists who'd like to respond, keeping it to just 1 minute so we end on time.
Okay, thank you so much. We have been doing so many things to just avail services in the routine service health service system, including essential nutrition services. But the kind of challenge that is being mentioned regarding the existence of the number and quality health care and nutrition care delivering individuals is very limited in the ground. And so integration is one important thing that we can consider to do it in a more efficient and effective way, so as to simplify and reduce the work burden and to increase our effectiveness and coverage of our essential services. Thank you.
Thank you so much, Galila. Let me ask a next question regarding what to do in emergency settings. So by its nature, wasting is exacerbated by natural and man-made disasters like war, drought, and internal displacement or migration. So in your experience, what could integration look like in emergency settings? And I wonder if Mulana or Stanley, you'd like to comment on this question?
Yes, I can add the fact that I think for the context of Ethiopia, where, as I mentioned earlier, at regional level, you see full integration of wasting treatment into, for instance, the health system. I think what then happens if there's an emergency is perhaps an increase of the caseload of children that are visiting the health posts or health centers or some of the general hospitals. At that point, perhaps that's only when partners could come and support. But we do not have here an experience whereby there's a separation of a sort of treatment of wasting, whether in emergency or as a regular sort of program, where sort of you create a parallel sort of system for treatment of wasting. So the integration naturally happens, but emergency, what it does, it just sort of increases the burden, the caseload. And then at that point, it's a matter of partners coming to support within the health system to reinforce the integration. Over.
Thank you kindly. Okay, well, due to time, that's all we have for the Q&A section, and apologies that we didn't have more time for that, but we've heard so much thoughtful, rich examples from the panelists and presentations. We received several questions on RUTF, including the transition of supply functions to the government, indicating a lot of excitement for this topic. I'm sure it warrants its own full session, and so if you'd like to see something along those lines, please write it in the Q&A as well so that we can help plan and prepare. On that note, I would like to thank all the panelists for their contributions, and we will move into closing remarks. It is my pleasure to reintroduce Hiwat Darseni, the lead CEO of the Nutrition Coordination Office from the MOH, please to say a few words on the way forward. Hiwat, over to you.
Thank you, Mary. Can you hear me?
Yes, please go ahead.
Okay. Thank you, Mary, and the panelists, all participants, for constructive feedback and question to think over to the realistic implementation of this action plan. So next slide, please. So call to action for all participants, like the UN agencies, the donors, and the implementing partners. So as you see from the presentation, Shipru's presentation, this global action plan estimated to incur 3.2 billion or around 60 million USD for the implementation. It is not considering the entire logistic, but for the facilitation, the capacity building, the others. So it is needed. So in the area of collaboration in way forward, so we need to mobilize from government treasury, the donors and partners, and the local capacity at the ground level. So we need to advocate for more resource mobilization. So more focus on domestic resource and the financing at all levels. The other one is it is as a priority, it is embedded in the Ministry of Health plan, and we are also trying to embed it in the Regional Health Bureau plan, annual working plan. So we are working on that regard and to further strengthen the inclusion of this plan into regional health and subnational level. The other one is to implement this 3-year plan. Still, we want to exert your support on the all partners in the area of funding, technical assistance, and learning and adaptation from similar contexts. So we are good enough in integration of this or implementation of the wasting, despite all the coverage and the quality limitation, but we are far behind on integration of moderate acute malnutrition or comprehensive wasting management in the health program in general. So we want to draw learning and adaptation from similar contexts. And the other one is we want to also know your support in the area of how to strategically translate this plan in and it has to be supporting budget. And the other one is to generate ample evidence in the area of integration, like for the successful integration. So we saw like the many participants of this webinar concern is to effectively integrate this into the program. So we need evidence-based, and we want to test small, and we then to scale up. So we want to generate new evidences in the area of this, and the other one is to cascade into subnational level and to strengthen the capacity at the subnational level for the effective implementation. Next slide, please. So one final call is to use the existing opportunity. So we have to maximize our effort on the using the existing opportunities, like the health extension program and other similar platforms at the community level, and some pilot programs like the Family MOAC and others, to use as an opportunity and springboard for this huge initiative. So we are good enough in the policy landscapes, from policy document to implementation guides and operational guides. So using all these opportunities and fragmented efforts by all stakeholders from national to sub-national and at community level. So we have to mobilize and come into center and concentrate our effort to effectively implement this gap, and at the end of the day to achieve our goal, the bigger goal, like to end, not to end, to make wasting less than 5% or insignificant in our context. So the other one big ask will be, even though humanitarian response is mandatory, we have to think of the resilient part. So we have to make a bridge between the humanitarian and development nexus for any of our supporters. So having said this, I would like to thank all participants, organizing team, the UNICEF and R40, and my team at the Ministry of Health, and the Elena Group Foundation for generous support for this webinar to happen. So thank you very much all, and I thank you. Over to you, Mary.
Excuse me. Thank you very much for the closing remarks, and thank you everyone, all of the panelists, presenters, speakers. Thank you to all of the attendees who've participated, and we will close the webinar. Thank you. We'll send a recording and slides out to everyone who's registered, and we'll follow up via email that way. Thank you, everybody. Have a wonderful rest of your day, wherever you are in the world.
Thank you all.
Thank you.
Thank you very much.
Thank you.
Thank you all. Thank you very much.
Thank you.
Thank
Take
you
care.
very much. Thank you.